discuss with you the psychotherapeutic drugs. Before I start discussing, I want to give you a little preview of mental health nursing in the United States. As you are probably aware, mental health disorders are highly prevalent in our country, and especially with this COVID pandemic, nurses can expect a higher turnout of patients with a lot of psychological behavioral problems. So this 8 weeks course cannot cover the entirety of learning the psychotherapeutic drugs. That being said, I also would like to tell you that you will be taking a complete course on mental health nursing. So you'll be learning about dealing with family health concepts about this group of drugs. My goal is to really get you familiar with some names and focus on some of the most commonly used drugs in this class. But there is no way that we could really go in depth and try to learn every single detail, in an hour or so of this lecture. So I highly recommend you to just get a broader view. But when I do a review with you, I'll let you know where are some of the really important things that you as nurses need to know when you go out to practice as novice nurses into the clinical world. So if you think of psychotherapeutic drugs, what should come to our minds is in life, when we are present with different situations, many of us have challenges. So when we have challenges, some of us feel really sad. We could get depressed, or some things can cause us a lot of worry or anxiety when things don't happen the way they were planned, or maybe family issues. So life brings its own challenges. So when we face these challenges, some of us, for short periods of time, we can handle it, but not for everybody. And it's very hard when things, life things can sometimes go above and beyond our capability to manage. So we might have anxiety. Some of them have depression, and some of them can have severe psychotic events like psychosis, right? So our mood can change, our behaviors can change based on what life brings us. So we need to remember that the very first stage, unless there's a risk for suicide or if there's a risk for severe psychosis, we try to manage it using non-pharmaceutical management. For example, let's say a patient comes into the clinic and says for the past 2 weeks they feel down. It doesn't mean they need antidepressants right away. So the goal is to help them try to find the emotional and mental balance if they can, without using pharmacological approaches. However, but for some of them it's very difficult, and if it prolongs for a long period of time, they might have to take some medications for short periods of time. But we do have to remember that there are some side effects, especially anything that deals with the neuro, right, our brain, and with the neurotransmitters that are present that reach the central nervous system, or when we play with any of these neuro or nerve-related neurotransmitters, there are challenges. So let's go ahead and think a little bit more about what are emotional and mental disorders. There are three main emotional and mental disorders, meaning that they can affect the individual's ability to carry out normal daily functions. Meaning it's, for example, if I feel down for today and then tomorrow I'm up and about and I'm acting in a normal way, and if nobody around me feels that I am showing any type of imbalance, or I feel that it's just normal process, there's very less chance that I might have some underlying mental disorder. However, if there are things that happen that interfere with my daily life, there's a possibility that there might be some underlying mental health disorders, right? So with that being said, there are several theories to try to explain what happens in the brain or in the emotional aspect of a person, but there are not very clear evidence to say what particularly does cause these. However, as of now, because we have found some drugs that interfere with the neurotransmitters that are listed here, it looks like that could be one of the theories. So that being said, you guys need to know the main neurotransmitters that are involved in mental health issues. Some of these might be very familiar with you, but not everything, right? Dopamine and epinephrine, serotonin and histamine, GABA and acetylcholine. I think among these, you probably heard about everything in this pharmacological course so far, right? Dopamine probably with Parkinson's, epinephrine, when we talked about Sudafed, right? Do you remember that? From our respiratory, and then serotonin with our anti-nausea medications with Zofran, right? And then histamine, we talked about when we did respiratory, the upper respiratory, and also when we did about the GI drugs. And GABA, I think when we did CNS depressants, right? Gabapentin, if you remember that. And then acetylcholine, you probably wouldn't forget this part, but it's large, right? And the parasympathetic nervous system. So if you look at these neurotransmitters, you kind of have a baseline from your patho and mostly from your form, I would think. So think about these neurotransmitters and see how interfering with these might produce some side effects. I think from looking at this, I know you could tell me the answer for the GABA. I know you could tell me the answer for the acetylcholine, right? I'm not sure about serotonin, but I do know with dopamine, you'll know. So the goal for you for this, this class of medication is to try to first identify the physiology of this neurotransmitter or the underlying patho with the neurotransmitters, which are usually the targets when we provide inhibitors, right, or receptor blockers type of drugs, right? So now let's look at these three classes of main disorders. The first one being anxiety, the second being affective or emotion or depressive disorders, and then the last one is psychosis. So based on these, we can give patients either anxiolytic drugs, meaning to reduce anxiety, or we could give them mood-stabilizing drugs to stabilize mood. For example, in bipolar, patients might have extremes of mania or depression. And then we have antidepressant drugs, and we could also give antipsychotic. So based on these classes, we're going to spend some time in each of these to try to understand each of the class. So one important thing to always know is the first step is not to provide any type of these medication. The first step is to try to provide non-pharmacological intervention and closely watch the patient if necessary. But again, remember, it's always important to screen them for SI, meaning suicidal ideation. Let's say you see a patient who's very depressed and they say that they've had a plan to hurt themselves. That means they have a risk for committing a suicide. So that's really, really important. And as nurses, we could be charged with negligence if we do not document it or provide the necessary next steps to help this patient. So always remember, if someone says that they're feeling down, and which is many times in these days when patients are admitted, they are asked this question: do you feel down? Do you feel low? Have you ever thought of hurting yourself? And if they say yes, then you ask them, do you have a plan? So if they say yes to both, that means there's an automatic risk for suicidal ideation. That means they need inpatient psych treatment, at least if for a few days, and then they could go outpatient. So just keep that in mind. And the drug selection usually, in this category is trial and error. Very unfortunately, we do not have very clear medications that really target the emotions, right? We human beings have emotions that are very complex, and I don't think we would ever come up to a drug that can really target the emotion of feeling sadness or the emotion of feeling anxious. But as of now, we do have some anxiolytics, for example, benzos. You probably know pretty well about this. I don't think I will have to repeat myself again. So I will let you to review this on your own and try to remember what we learned about in terms of its risk for abuse and dependence and depression and withdrawal, and what are some safety measures we need to teach them. And of course, we know it helps to calm them down, but if in higher doses, it could become sedative / hypnotic, right? And then have them potentially go into death, right? Coma and death, higher doses. So patients can OD on them. And I say OD, overdose, right? So teaching big time with benzos becomes important. So that's the anxiolytics. The next group of medication is mood stabilizer. If you look at your booklet, the only mood stabilizer we have here is lithium. So lithium has a very interesting history. In the 19th century, it was accidentally found. It's a metal, right? It's a silver colored metal. You probably heard of lithium batteries too, right? So this is a metal that was accidentally found, and it was found to help. It was found in a kitchen when it reacted with uric acid, and then they found that this could be helpful for treating manic episodes. And till date, it's still being used. I really expect you to know lithium very well. I'll give you important points here because there are many times bipolar patients can get this for severe manic depressive episodes. So if you think of bipolar, patients with bipolar will be in a manic condition for a few weeks, like say 3-4 weeks, and then that will be followed by depression for like 3-4 weeks. So when we talk of depression or when we talk of mania, it's like extremes. It's not that they're like depressed, like, okay, they don't want to eat, or they feel lack of energy, they can't sleep, there's extreme fatigue, and they don't have any interest in doing anything. And it's hard to miss that type of depression. So first things first, so with lithium, there are a lot of side effects, okay? Especially when the toxic levels are reached, which is about 2 milliequivalents, right? So level 6, if you look at this nursing implication, there's a narrow therapeutic range. You can give up to 1 point, the blood levels can be up to 1.5, and then maintenance is between 0.6 and 1.2, right? Depending on, I'm not expecting you to know how much for every like acute versus depressive episodes, but I really expect you to know, what is the therapeutic level, and then when can it become toxic, and what can be the symptoms of toxicity. Symptoms of toxicity include GI symptoms, particularly, and then central nervous system, like nervous system. For example, somnolence, meaning like lethargy or confusion, seizures, right? And if left untreated, it could potentially cause death. The other thing is it's important to keep the sodium level in the normal range, because if you don't, then it could increase the levels. And the other thing to know is that lithium can cause hypothyroidism in women, particularly younger women less than 60 years old. So when women take this lithium, it's important to monitor the TSH levels as well. It could cause some weight gain as well, but not as common. But the toxicity is a huge piece. An important thing to know here, which I don't have it in the sheet, is to know the medications that can interact with lithium. The drugs can interact with lithium include the diuretics, because the kidneys get affected when patients take lithium for longer periods of time, because remember, it's a heavy metal, right? It can also interact with NSAIDs, that's non-steroidal non-steroidal anti-inflammatory drugs, and ACE inhibitors. So furosemide, ACE inhibitors, and NSAIDs. I think the mechanism of action is not really understood in terms of lithium. It's the thought is that it can help with the serotonergic pathway, meaning the neurotransmitters, serotonin, which helps, for anxiety, which is usually given for depression, or anxiety, depending on, how it books, how it's blocking, what it's blocking, So then the next group of class of drugs are antidepressants. So if you look at antidepressants, we have a lot of medications in this category. So there are the first generation antidepressants, and then the second generation. The older drugs are the tricyclic antidepressants and the monoamine oxidase inhibitors, right? MAOIs. You've probably heard this before. I think we talked about this briefly somewhere. So, anyways, the tricyclic antidepressants. So, the way they work is to block the the reuptake of neurotransmitters that are accumulated in the nerve endings. For example, it could be they prevent reuptake of serotonin. So when we give these tricyclic, for example, Alevil, right, amitriptyline, what happens? It blocks serotonin, but then it very broadly blocks, and in such a way that what happens is there can be potential sedation, there could be hypotension, there could be urination problems, muscle tremors, and it's highly contraindicated with patients who have cardiac or if they're pregnant. So this is what I want you to know. These drugs are not very common, even though given for when patients have like extreme, cases where they cannot tolerate SSRIs. One thing I've seen this given is for treating anorexia nervosa. So that's tricyclic antidepressants. The next one, MAOIs, or monoamine oxidase inhibitor. The name gives it away. It inhibits the monoamine. So if you think of amines, those are mostly neurotransmitters. They are given for depression again. An example to know is selegiline. So I'll expect you to know this drug selegiline. So selegiline, know this as MAOI, and the selegiline reacts with food that contain tyramine. So the amines, remember the monoamine and tyramine, and they can cause hypertensive crisis. So when you think of, I would think you can remember this more from a sympathetic response view, if that can help you. It can lead to like stroke or even coma or death. So when patients eat these foods, we have to be really, take this medication, we have to be really careful and teach them to avoid anything that was fermented or aged. For example, red wine, right? Or if they are led to be aged, like cheddar cheese, or even the beans, like they call like fava beans. Some of the yeast extracts can also interact. Some pickled meat, so anything that was fermented or that was cured or matured and kept for long periods of time for aging, and of the cheese and things like that, they should be avoided with selegiline. That's the MAOI. And then the newest and most commonly used generation, or the newer generation drugs, are the antidepressants. So we have two classes in that. The first class is the SSRI, that's a selective serotonin reuptake inhibitor. Okay, so if you look at this, you should know that it makes sure that there's more serotonin available. From that, you could figure out that when patients have more serotonin, right, they're going to feel less depressed. I hope that helps. So serotonin particularly helps with preventing depression. So that's how it keeps your mood high, if you want to put it in the other way, right? That's why we call it SSRIs, as selective serotonin reuptake inhibitors, meaning in the post-presynaptic pathway, there is more availability of serotonin if you give this medication, therefore preventing, a severe depression, which is explained well in the sheet too. So there are some complications. The names of these drugs are the prams, the citalopram, the escitalopram. There's also these ines, or the tines. I think tines might be the easier way to remember, like fluoxetine, paroxetine, and duloxetine. Those would be good ones to remember from the exam point of view. Those are Prozac, Zoloft, most commonly used ones. Sorry, I think duloxetine is more of SNRI. So just the first few should be good. The citalopram, escitalopram, and fluoxetine and paroxetine. Okay, if you remember those, you should be in a good place. I'll just test you on those. And then the SNRI. So what they do is they inhibit the reuptake of the neurotransmitters, both serotonin and norepinephrine. You know what norepinephrine does, right? It's a sympathetic neurotransmitter. So these levels, if you think about it, if I have a sympathetic response, I'm not going to be just depressed, right? So if I have more serotonin and more norepinephrine available, I will not feel depressed. So that's the mechanism or the pathway by which the SNRIs work. So there are some symptoms listed here. Make sure you review some of these, especially hyperthermia, rhabdomyolysis, renal failure, cardiac dysrhythmias. And then with the SSRIs, patients can have something called serotonin syndrome. For example, if a patient is placed on one SSRI and one SNRI, there's a risk that they may have excess of, the sympathetic, the serotonin available to them that can cause, delirium, right? Nervous system changes, agitation, and even cardiac problems, right? So cardiac and nervous system, right? Those are things to remember. So the last but important antipsychotic class from this psychotherapeutic drugs is that's given for schizophrenia or psychosis. For example, when patients have hallucinations and delusions, right? If they see things, there need to be stronger medications. It's not unusual for patients to come into the ER with severe psychotic episodes, wanting to kill themselves, seeing things, being worried and trying to run away from home. And it's very sad when those things are seen. And it's hard to prevent those psychotic episodes many, many times. Some of the medications that are given for this very commonly is Haldol. It's a very old drug, but many times it's really works well in antipsychotics. And you have a lot of drugs that start with pine, the clozapine, the quetiapine, the olanzapine, and then you have the dones, the risperidone, the ziprasidone, right? I expect you to remember Haldol and quetiapine, and then risperidone, at least one in each. So particularly for risperidone, I want you to know that it can cause something called gynecomastia, so breast development and sometimes secretion of milk, because it increases prolactin secretion. So risperidone, important to remember. It's given usually for patients with ADHD. Also something to keep in mind with risperidone. With the haloperidol, that's Haldol, and clozapine, there is possibility of agranulocytosis. That means WBC levels might go down in patients. And then in other drugs, for example, with quetiapine or with Haldol, with this antipsychotic group, patients can have extrapyramidal symptoms because they can block the dopamine when they block the dopamine receptor. So these drugs are made to target the dopamine. So if you think of dopamine and Parkinson's, if you try to block them, they could have, jitters and stuff, because that's exactly what happens in Parkinson's, right? And tardive dyskinesia. I think you learned about this already when you did the metoclopramide and adrenaline, right, for the anti-nausea medication with dopamine. So I think with this, I would like you to really read well about the nursing implications, especially to teach them how long it'll take and what to ask them. And if they say they feel like they want to hurt themselves, what do you do? And important to make sure that they take this along with psychotherapy, like something like cognitive behavioral therapy or counseling. And then some patients, after taking this drug initially, might want to hurt themselves even more. So really closely to watch them and obtain vital signs, blood pressure readings, obtain liver and renal function in certain conditions. And then if they are in the inpatient setting or even outpatient, sometimes they will not like to take those drugs, right? Because they're always planning to hurt themselves or doing something. So it's important to make sure that the pills are swallowed and they're not keeping it inside their mouth. So I think that's all for this lecture. I hope this was useful. And we will meet in